Welcome everyone to our third webinar on TriClip Therapy. My name is Sarah Johnson. I'm a Senior Product Manager at Abbott Structural Heart. Today we will continue our series on imaging with a deep dive on a critical skill for TriClip imaging, 3D multiplanar reconstruction. We have brought back our imaging experts from two highly experienced centers for this topic. I'm pleased to reintroduce them. Dr. Stephen Little is the John S. Dunn Chair in Clinical Cardiovascular Research and Education and is the Houston Methodist System Director for Structural Heart and the Program Director for the Cardiovascular Disease Fellowship Program at Houston Methodist Hospital. A longtime member of the American Society of Echocardiography, Dr. Little previously chaired the ASC Guidelines and Standards Committee as well as the Structural Heart Disease Task Force. He is the past president of the ASC. Dr. Lucy Safi is an associate professor of medicine at Icahn School of Medicine and currently works as a structural heart imager and interventional echocardiographer at the Mount Sinai Hospital in New York City, one of the highest volume sites for TriClip interventions in the US. She completed her cardiology fellowship at Cooper University Hospital and advanced echocardiography fellowship at Massachusetts General Hospital. Dr. Safi has been an active member in the American Society of Echocardiography and currently serves on the ASC Board of Directors. We are looking forward to their expertise as we continue the conversation on imaging for the tricuspid valve. Here's our agenda for today's program. First, Dr. Little will do a review of the imaging criteria for TriClip therapy and how to determine what will make for an easier or harder case for implant teams that are just learning the procedure. Then Dr. Safi will take us through a step-by-step of multiplanar reconstruction, a critical skill needed for TriClip cases. Before we get started, just some quick housekeeping reminders. This webinar is being recorded and will be available for on-demand viewing. Questions can be submitted at any time through the Q&A feature on your screen, and you will be receiving a survey afterwards, and we appreciate your feedback on the program. And I will now pass it over to Dr. Little.
Thank you, Sarah. It's a pleasure to be back. Thank you all for joining us. We'll jump into a little bit of the quick indications for use of the TriClip therapy. So the G-Force system is indicated for improving quality of life and functional status in patients with symptomatic severe tricuspid regurgitation, despite optimal medical therapy, who are at intermediate or greater risk for surgery and in whom transcatheter-edge-to-edge repair is clinically appropriate and is expected to reduce the TR severity to moderate or less, as determined by a multidisciplinary heart team. There are some contraindications, including intolerance or allergy or untreatable hypersensitivity to the procedural anticoagulation. Likewise, untreatable hypersensitivity to the implant components, namely nickel titanium alloy or cobalt chromium alloy. Active endocarditis or valve infection are also contraindications. So we have already had a webinar, and I'll quickly review some of the things we talked about. So the TE screening and the pre-procedural TE are very important, and we're going to focus today mostly with Dr. Safi taking us through MPR. But what do we need to move forward for the consideration of TriClip therapy? First is to really confirm the diagnosis, and that can be initially through a transthoracic echo. TEE typically is to confirm the mechanism of the TR, and also to do that formal evaluation for the elements of TriClip therapy, including gap, width, and all of the imaging views that you need during the TE of the procedure. You also have to identify the mechanism of TR. And we've talked about this before, but this includes primary TR, which is roughly 10% or so of all cases, atrial functional MR, ventricular functional MR, or CIED, implantable cardiac electrical device related TR. We want to evaluate the tricuspid valve anatomy and the suitability for T-TEER. We have to look at where the jet origin is and understand what scallops are involved, identify and measure the leaflet lengths. Importantly, and we'll demonstrate today, measuring the gap and identifying how that impacts patient selection. And we have to get down to moderate or less as a target, and you have to have some reasonable expectation that you can put a clip in a sufficiently strategic place or several clips to achieve that goal. You have to have a suitable plan for the intervention. So that includes what are the views that are best? Is it a short axis view? Is it a mid-esophageal view? Is it a deep transgastric view or a deep esophageal view? Sort of understanding that. And ultimately being able to predict which patients might need ICE, intracardiac echo, as an adjunct to TEE to effectively perform the procedure. patients with left heart prostheses, patients with significant calcium of the aortic or mitral valves, patients with implantable electronic devices. They often will need ICE. Or patients, sometimes we are anticipating multiple TriClips being deployed, and sometimes ICE will be very helpful in those scenarios. So when you've kind of considered all of that stuff, you formulate a treatment approach to the intervention, sort of anticipating number of clips and where they'll go. So one of the things to consider in general when you're approaching a patient and you've got the imaging is this concept of relatively easy cases, the medium cases, and what will be considered a hard case, and for some centers an undoable case, or case you don't want to tackle without significant experience. So just to quickly review the easy cases, or the easiest cases, with the leaflets that are typically classically 3 identifiable cusps. Lengths are greater than 7 millimeters in where you want to deploy the TriClip. Gaps are relatively small, less than 6 millimeters. Ideally, a septal anterior target, so the greatest place for the TR is between the septal and anterior leaflets. That's a relatively easy place to deploy a clip. No electronic leads, and ideally normal RV size and function. And of course, good image quality. Good everywhere is ideal, from the esophageal to the transgastric. So when you have all of those things lined up, you can anticipate a relatively easy TriClip case. The harder ones, as you can imagine, more leaflets, greater length that isn't still greater than 7, but a gap that now starts getting bigger, larger than 7 millimeters. Septal posterior as your landing zone tend to be a little more challenging. Leads and the artifact and the shadows and the catheter interaction that leads sometimes create are absolutely concerns and make cases always more challenging. But then when your imaging gets limited, so if you don't have a good mid-esophageal or you don't have a good distal esophageal, you really have to have eventually some sort of grasping view, but that's where it gets challenging. And then of course the hardest ones were multiple leaflets, short leaflets, very large gaps. An anterior posterior jet location can be really quite challenging because of papillary muscle that separates anterior and posterior. Leads again, prior tricuspid intervention, for example, a surgical ring can be present, and that's not a contraindication, but it can certainly cause shadowing and make imaging more challenging. Severe pulmonary hypertension, severe RV systolic dysfunction, not necessarily impacting the elements of the screening or the performance of the procedure, but the clinical expectation of recovery will be less in those patients. And then, of course, poor image quality. So again, almost the traffic light approach to patient selection is important to sort of think about and to recognize. And as you plan these cases or decide not to do these cases, this is a useful format. Just an example of the measuring of gaps. So we have 2 patients shown here. Patient A, you can see them, so an inflow, outflow view positioned across the septal posterior plane. You see a measured gap on the right there of approximately 7 millimeters. That would be reasonable. You have the color on. You can see the color goes right through the measured gap. It's not dropout, it's real. So that's a patient who would be in that sort of perhaps green to yellow zone. Patient B, again, an inflow-outflow view. Here the gap is measuring 14 millimeters. That's a very challenging case. Perhaps might be prohibitive. You would want to review that patient and see if more medical therapy, more diuretics, is there some way to lessen that gap through different means. And then finally, an MPR shown on the right, and Dr. Safi is going to take us through this in a moment. Sort of how do we set this up? How do we use this? And sort of aligning at the leaflet tip. Sometimes it's obvious on an X-plane view, but sometimes MPR can be very helpful to just be confident that you're truly at where the gap is and where you're going to be deploying the device potentially. And that's a very useful tool for measuring gaps. So planning for these complex imaging situations, we have the anatomical considerations of the prior surgical or transcatheter interventions, CIED leads, thickened and tethered leaflets, malcoaptation gaps. The challenging imaging, where sometimes anatomic abnormalities, a horizontal heart, dilated aorta, dilated atria alone. One of the common ones, which can be very challenging, is a hiatal hernia or even prior lung surgery. So these sort of review of the patient chart and the patient history can be very important in predicting the imaging challenges. And then the acoustic shadows from almost any prosthetic device that's in the heart, lipomatous septum, or even atheroma or annular calcification of the mitral valve. Without further ado, I'd like to introduce Dr. Lucy Safi, who's going to take us through some multiplanar reconstruction details of MPR. Over to you, Dr. Safi.
Thank you, Dr. Little, and it's great to be with you here again tonight. Multiplanar reconstruction is often highly interesting topic, and a lot of questions usually revolve around this topic. So I'm honored to be able to go through it with you. And so what is 3D MPR? Well, it's a technique that allows you to visualize the 3D structures inside of the heart using a 3D volume set. And if you think of it, it's almost like imaging a cardiac structure on the sagittal, coronal, and axial views. So you're able to really get a three-dimensional view of that particular structure all in one image. And so oftentimes we like to display it in this 4-box configuration here. And we're going to go through it and hopefully answer any potential questions that you may have. And so 3D MPR, in order to build a really good image, you really have to start with a good 2D image. So going back to our first webinar where we described how to get the basic views, again, you want to build your MPR wherever you have the best 2D image, whether it's mid-esophageal, whether it's your distal esophageal, or even from your transgastric. You can get a 3D volume set from any of those 3 views and build your MPR. And so let's go through it step by step. And here's our starting view. So this is a distal esophageal view. You can see the coronary sinus coming in here on the top right of your left image. And then you angle up to your best inflow, RV inflow view. So you can see your aortic valve there on the right. You can see this particular patient actually has a CIED lead across the tricuspid valve. So this is our best view that we determined on our screening TEE. And we went ahead and built a 3D volume set. So for this particular example, on the left there, we built a 3D zoom and honed in on that particular tricuspid valve. Now, you can display it with a single view, so just the 3D like you can see on the left, or you can actually change your display, and this is an option on your console, so you can display it in any one of these 5 views shown down here. Oftentimes when we're doing a tricuspid valve intervention, we like to use this quad screen that you see on the right. And so after you obtain your 3D image, and this could be done live at the time of the procedure, or you can go back to it when you're done with your TE and build your and use your MPR to better optimize the picture. So you can select on Philips systems, you can select a multi-view, which will really allow you to crop into the tricuspid valve and give you the best imaging planes for your tricuspid intervention. And so here you can see in our multi-view, once selected, you'll get these 4 boxes. So your green, red, and then your blue, which correlate. So in the green box, this red line will correlate with this red box. Sorry, I can't see. So this red line here will correlate with the red box on the top right. And then the blue plane here will correlate with the blue blocks on the bottom left. So you're able to orient the planes, and what you want to do is orient your blue plane to be right across the tricuspid valve in both your green box and in your red box. And so when you're orienting and shifting your planes, please don't forget to lock your planes. So prior to moving anything, right on your console here in the center, there's a lock plane, and you want to make sure that your planes are locked before manipulation. And so now on your reference planes, like I mentioned, you have a green, red, and your blue. Your 3D will always follow whichever is highlighted on your console plane. So here you can see in the bottom that your blue plane is highlighted, and therefore your 3D image in the bottom right will correlate with your blue plane. And you can actually select green or red, and then your 3D will be a 3D representation of whatever is in that selected box plane. So now that we understand the console, we've set up our planes, and on the right side there, you can see a great example of how we set up our planes across the tricuspid valve. So you can see the blue is right across the tricuspid valve, and the blue line is across the tricuspid valve annulus in the green box and in the red box. So you have a beautiful short axis view of the tricuspid valve on the bottom two boxes, on 2D on the left bottom and in 3D on the right bottom. And so now that we've oriented our planes, we got to make sure that our aortic valve is in the location that we want it to be. And most centers now place the aortic valve at 5 o'clock. So here you can see it on 2D that the aortic valve is at 5 o'clock if we're using a clock representation. And if you can't see it on 2D, you can usually see it well on 3D. So you would want to rotate your Z plane in order to get your aorta here at the 5 o'clock position. Once it's in the 5 o'clock position, then you're able to really identify your tricuspid valve leaflets. You'll know that this is your septal leaflet here. You'll know that this is your anterior leaflet here. And then you'll know that this is your posterior leaflet here. And so how do we grasp using NPR? Well, if we set up our planes with the grasping view intended to be in the red plane, you can see down here in the blue box that my red plane is cross-secting the anterior and the septal leaflet. So I've aligned it that it's perpendicular to the leaflet coaptation plane. In that situation, then my red box will be my grasping view. And in this view, you can really see the leaflets well. There's a nice pair there. You can see that CIED lead actually there as well. And you can freeze frame and measure the leaflet lengths, and you can also grasp and do anything that you need in this view once aligned properly. You can put on color Doppler, and color Doppler will also show you if the TR is orienting there. And you can see it also in cross-section at the bottom part of that screen, where you can see your 3D as well as the 2D and short axis all in the same time. And so let's build it. It really doesn't take too long. So we optimize our 2D image, we get a 3D zoom, and we immediately lock our planes. And then I usually like to orient my red plane first. So you can see that I'm lining my blue cursor in the red box. And then I move on now to the green plane, and I'm orienting my blue plane right at the tricuspid annulus. I'm rotating now my aorta to be at 5 o'clock, and I'm placing my red plane through the coaptation in order to get my grasping view. When it went fast, I'll let it play again. So 2D is obtained, a good 3D volume set. I immediately lock my planes. I rotate the blue line to be at the tricuspid annulus. And then in the green box, I orient my blue plane to be at the tricuspid valve leaflet tips. And then I can crop out anything I don't need and rotate my aorta to 5 o'clock, keeping my red plane perpendicular to the leaflet coaptation plane. MPR can be done, as I mentioned, from the mid-esophageal, from the distal esophageal view, whichever you have the best plane. Make sure that you immediately lock your plane so you're not messing up your angles. If your lab likes aorta at 5 o'clock, we usually rotate it to 5 o'clock in order to just mimic what a transgastric short axis would be in terms of your blue planes and also in your 3D. And then make sure when you're rotating your planes, if you're going to be grasping in your red box, that your red plane is perpendicular to the leaflet coaptation plane, right where you want to grasp with your TriClip. You can build your MPR also from your transgastric if that's your best image. There's a couple ways to do that. This is one example of how. So here you can see that a 3D volume set was already obtained from a beautiful transgastric view of a tricuspid valve. In this particular example, our blue plane is cross-secting between the anterior and the septal. So our blue plane would be our grasping view down here at the bottom. And our 3D was set to mimic that grasping view. So you can do it this way, or you can do it where your grasping view stays in the red plane. It's just based on how you're going to orient your planes after the image is obtained. So here's another example of keeping the grasping view in the red. So a 3D volume set of the transgastric was obtained. My blue plane was set to be at the tricuspid valve leaflet tips in the red box. My crop plane was adjusted to delete everything I don't need. And my aorta was confirmed at 5 o'clock. So I'll let this play again. It didn't seem like it started at the beginning. My apologies. So here's the 3D that was obtained from a good 2D. So good 2D. And then my 3D volume set was set. I went ahead and locked my planes. I rotated my blue plane in the red box to be at the tricuspid valve leaflet tips. My green box is already aligned properly. So then I oriented my blue box to have my red line right where I want the clip to go in the anterior septal coaptation plane. So now my grasping view is on the red. So here's a comparison of the 3Ds that can be obtained from the transgastric full volume, from the esophageal 3D zoom, and also for using 3D ICE. And they're all comparing the pros and cons of each of the technologies. So I'll leave them there for your reference, and you can go through them. But they all have their benefits, and being able to be proficient in all of them and understanding the knebology is something that's extremely important for these procedures. So in summary, 3D MPR is critical for a T-TEER procedure and imaging. It can be used for trajectory, for alignment, for advancing into the tricuspid valve, but pretty much every step of the procedure, including grasping. It allows you for simultaneous visualization of all 3 views of the tricuspid valve at the same time, and also gives you a 3D image. This is very helpful because it can reduce potential injury to the patient's throat by manipulating the probe up and down from mid-esophageal to transgastric, and helps you overcome any kind of imaging challenges using this technology. So with that, I wanted to thank you.
Thank you, Dr. Safi. That was a great run through in detail on MPR. We really appreciate the tour here. We do have a few questions as it relates to MPR. So our first one here, can you elaborate on if an MPR from a transgastric view is more ideal for grasping view rather than utilizing the mid-esophagus view to generate an MPR?
I think that's a great question. I wouldn't say that it's more ideal. I would say that, you know, the best or the most ideal MPR should be built on whatever you have the best 2D for, whether it's mid-esophageal or distal esophageal or transgastric. You know, routinely, I find it that most of the procedure is done in the mid or distal esophageal. So it's really easy to then just build your MPR in that view. But if you don't have a good mid or distal esophageal view, then you can certainly build your MPR from the transgastric and do the procedure using that image.
Okay, thank you. Another one, when is the TEE MPR utilized versus biplane at the bicom view and confirming with transgastric?
You know, I'll jump on that first, Lucy, but I'd like to hear your answer to this one as well. I think the reason I think there was so much focus on MPR is that it's becoming increasingly recognized that it's increasingly useful to see everything at once, to be able to see trajectory and implant and 3D and orientation and positioning across the target landing zone, the intercommissural, if you will, or the coaptation zone. But it's not always necessary. You can get away often with a good X-plane view, a bicom view. You can get away with a single view for your deployment, but it makes it easier. So the trick to this is there's a lot of new knobs, and the message would be, don't only do this mid-case. If the only time you try an MPR is during your procedure, you probably will be frustrated because you don't know the knobology. So a lot of us do a lot of screening of valvular heart disease, whether it's mitral, prosthetic valve, tricuspid. So investing a little effort into how you set up an MPR, how you manipulate an MPR, and just seeing that you don't have one screen, you've got 4 screens of data. And even that takes a minute to assimilate. There's a lot going on in a well-done MPR. You've got medial and lateral and anterior and posterior and short axis, and sometimes collar all at once. But it's really worth the investment to do. I would just add one thing, that once you've got it and it looks beautiful and it's incredibly useful, it sometimes does take a little maintenance. The esophagus likes to move with the probe, and then even an MPR can degrade, because these are live MPRs. These aren't MPRs captured and looking afterwards. It's live, and you have to recognize a little bit of maintenance and probe advancement or probe withdrawal or probe tension to maintain the image. It doesn't always stay there. If somebody has natural esophageal peristaltic motion, things can change. So it's incredibly useful. It does take a little bit of training and a little bit of practice, but I would say it's absolutely worth the effort. And my final addition to this long comment is that the machines are getting better. So the MPR of 3 years ago is not the MPR of today in the modern machines. The temporal resolution is better, the spatial resolution is better, and therefore the utility is better. So if you didn't like MPR 3 years ago, try MPR today. It is different.
I absolutely agree with that. I think that there's been significant improvement in the technology recently, specifically with the color MPR. I think that has gotten much better, both in the TE aspect and also in the ICE aspect. And being able to use all the tools that you have at your fingertips can make these procedures really easy. I think the fact that with the MPR, you're able to see those 4 views simultaneously really does help the proceduralist. He or she can see in one image whether, did the clip slightly rotate, or is my trajectory on axis? And it really does minimize the trauma to the patient's esophagus. But to be honest, you can't get it in every patient. And if you have great 2D pictures with biplane, sometimes that's all you really need.
Great answer. Great explanation there. I guess maybe a final question here would be, what are some good ways to practice MPR? If you're not doing MPR today and you're trying to learn it, are there some good tips and tricks to get good at it in a low pressure situation? Like, how would you advise people to kind of really get going and get better at it?
I would recommend. Oh, go ahead.
No, you go ahead, Ancestor.
I usually, what I tell people who are getting used to using MPR, starting with it, is to practice on normals. Practice when you have time in the echo lab. You don't, as Dr. Little mentioned previously, you don't want to walk into a TriClip procedure and, try it for the first time. It's something that does take time and practice. But if you looked at my videos, building the MPR doesn't take more than 20 seconds. You can get really fast at it and sessile, but I would say practice in the echo lab. You can practice offline and practice on normals. Dr. Little, what are your thoughts?
I fully agree, Lucy, as usual. I would simply say that recognizing that you can't make a good 3D anything from a bad 2D. So sometimes people go to 3D thinking it'll improve or provide some eureka visualization that couldn't be seen on 2D. So my approach to teaching our fellows is, if you've got a really nice 2D image, that's the time you do a 3D. And you learn from 3D, whether it's just a zoomed volume and you want to spin it and manipulate it, add some color, understand the orientation, but particularly in MPR. If you've got a good 2D image, whether it's an inflow, outflow, or and even a bicable view where you see just a little bit of the tricuspid valve, do your MPR then and understand how to manipulate, how to spin, how to use the Z rotate, how to manipulate the planes. It's literally a 10-minute learning curve. But it's well worth the investment. But you have to practice on either normals or people with, you're not in the throes of an intense procedure.
Wonderful. Great advice. Well, thank you again, Dr. Little and Dr. Safi. MPR is such a critical skill for TriClip procedures, and I know that your teaching on this topic will no doubt help programs that are just getting started with TriClip or that are just getting started with MPR. So this concludes our discussion for today, and we hope that you'll join us again for future webinars on TriClip therapy. Thank you again, and take care.